Welcome everyone to today's webinar. I am Emma Goodman with Becker's Hospital Review. We will begin today's webinar with a presentation and a panel discussion, and we'll have time at the end of the hour for an audience question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled "Enter a question for staff" and clicking send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our panelists. Dr. Eric Poon is the Chief Health Information Officer for Duke Health. He also practices primary care internal medicine at the Durham Medical Center as a part of Duke Primary Care. We're also pleased to have Dr. Brian Griffiths with us today. He is an assistant professor of medicine for Duke Health, and he splits his time between patient care and medical education, as well as acting as a Mastro Care physician champion. Finally, we have Dr. Chris Snyder. He is the Chief Medical Information Officer and the Physician Advisor for Utilization Review, Case Management, and Performance Improvement at Peninsula Regional Medical Center, as well as a practicing hospitalist. I'm now pleased to turn the floor over to Dr. Andrew Mellon, Chief Medical Officer for Spoke, to begin today's presentation and moderate today's discussion.
Thank you, Emma. And it's an honor for me to be here and to share some insights with my colleagues from Peninsula Regional Medical Center and my colleagues at Duke University. Before we jump in and go through a series of questions about healthcare communications, we'll first have Dr. Poon talk a little bit about Duke Health.
Great, thank you, Andrew. So Duke Health is located in Durham, North Carolina. It is a health system comprising of Duke University Hospital and 2 regional hospitals. You see our statistics here, and the mission at Duke Health is to advance health together and to deliver tomorrow's medicines today. And we pride ourselves at being able to deliver the best in class in terms of clinical care and being a leader in knowledge discovery.
Thank you. And now, Dr. Snyder, maybe a little bit about Peninsula Regional Medical Center.
Yeah, thanks, Andrew. Yeah, we're located in Salisbury, Maryland, which is about 120 miles east of Baltimore. We live on the coast, and we have about 3,500 employees, 400 community-based physicians, and do a very good business of admissions for a rural center. There's 21,000 admissions, and our ED is extremely busy for a small town at 95,000 visits. So probably about the 4th or 5th largest hospital in the state of Maryland. We also have a 280-bed, 88-bed acute care beds that we manage on a daily basis. I'm part of the hospitalist group here and have been here for over 20 years. We installed Epic in 2015, or a 2015 version, excuse me, November 1st of 2016. So we're fairly new with Epic, but fairly pleased with our progress so far.
Great. Well, before we jump into some of the questions, I just want to provide a little bit of context about healthcare communications today. It's really been a fascinating evolution for me to see how healthcare communications have changed. My father is a physician, and I have very clear memories of growing up when his pager would go off while we were driving in a car. We'd have to find a gas station. He would have a stack of quarters, and we'd sit in the car while he went into the payphone booth to call back. And today we have this very sophisticated, highly interconnected world that really is core to keeping a health system running. When I think about healthcare communications, there's really 3 core components that I think about, because it's not just a simple phone call or text messaging solution, but it's really these 3 things. First of all, it's a way to communicate, a common way to communicate for every single person that's helping care for the patient or help keep the health system running. It's a way that knows the preferences of how to communicate with people. It's a way that knows who's available or who's on call in a given role. And it's a way to make sure that everyone is talking in that same language. So one common way for everybody to communicate. The second part of healthcare communications is communication core changes in patient status or in the patient care process. And you do this by connecting to the devices and connecting to the EHR and connecting to other kinds of patient monitoring systems and empowering those mobile healthcare workers to be able to see and act on any of those changes as soon as they occur. And the third thing is supporting the very different and diverse communication workflows that occur in a health system, whether it's the care team talking to each other, whether it's an emergency event where you have to rally the cath lab team from home when someone shows up with a heart attack, whether it's that first point of contact when someone calls into the health system, or whether it's things like patient transport and just keeping that patient flowing and keeping the hospital operations moving. So all those things together comprise, in my mind, healthcare communications. And over the course of the next 45 minutes or so, we'll be talking about different aspects of that. So my first question, which I'm going to address to Dr. Poon, is as a leader in your health system, what do you think your role is for fostering these critical care team communications?
So Andrew, thank you for that great question. I think first and foremost, as a physician leader, I find myself really bearing in mind the importance of interdisciplinary communication. I think medicine is rapidly evolving into a team sport, and it is really important for all of us to make sure that when we talk about communication, we think about how the different disciplines can come together as a team to take care of the patient. And I think another paradigm that's worth mentioning is that we keep the patient at the center of everything that we discuss and think about. And as technology evolves, I think it's part of our role in leadership to think about how to maximize the use of existing technologies and to leverage new technologies to facilitate communication, be it in the domain of population health or increasing patient satisfaction or simply empowering the patient.
Great. And Dr. Seider, I know you've thought about this a lot too. What's your perspective?
Yeah, I totally agree with the team approach. We do bedside rounding and have shown significant improvement in patient utilization numbers of length of stay and documentation, et cetera. We're working with case management. So the care team really needs to have that ability to have an open visibility while still protecting patient information, and utilizing tools in the paging world for more urgent items such as code blues, rapid responses, and also even Muse alerts at this point, which is integrated with our EMR. We found some really powerful ways to leverage the communication tools that are available from Spoke.
Great, thanks, Chris. I think all of us are well aware that many patient errors and sentinel events are due to communication challenges, whether it's a dropped handoff, whether it's someone not being aware of information, or whether just something getting lost in transmission. And so as I talk with health systems across the country, what I'm seeing is that they are elevating these communication technologies and tools, really moving from what used to be thought of as just purely a telecom or an IT kind of infrastructure tool to something that's more of a core part of how the health system runs and how the care teams need to provide excellent patient care and safe patient care. So as this has been elevated, Chris, maybe in your organization, how have you thought about this evolution of communication technologies and elevating it to that level of your EHR?
Well, orders are somewhat of a level of communication in itself, and extending those orders fingers into other disciplines or capabilities. For example, consultative orders. We found that utilizing the paging tool within that consult order really gives physicians, and physicians, we're busy guys and ladies, and we honestly really need to have the tools within our workflow so we're not having to silo jump into multiple password systems and get in and out. So putting that information in the workflow and integrating that into your EHR, it's going to do nothing but drive people to want to use it, because if it makes it easier, obviously the providers, the staff are going to jump on board with that much sooner than if you don't. So, I mean, really getting the clinical leadership to understand that and to adopt that is your first step, and then making sure that when you do put it in there, it's consistent and targeted. So targeted as far as which discipline and communication needs to go to that discipline.
That's great. Dr. Poon, what are your thoughts on this?
Well, I agree with everything that's been said. I also like to add that I think part of our role as we integrate different technologies to support communication, we need to be very mindful about potential unintended consequences. I think every time we introduce new ways of communicating between different disciplines or different clinicians, we want to make sure that we don't actually introduce any barriers to any real communication that needs to happen, or that nuances don't get lost in translation.
Great. Thank you, Dr. Poon. Okay, let's shift to another question. And Dr. Poon, this one we'll start with you on this one. You did mention Duke Health's mission when you started, and you know, how do you see communication technologies, and the processes around those really helping you align with your organization's mission?
Yeah, so I think that as you can see from our tagline for the mission, advancing health together, we really are thinking about how different parts of the organization can really rally around the patient to deliver the best-in-class care, and to use the opportunity to advance the state of science. And communication is at the core of what we do. We have invested heavily in the Epic technology platform, and we are leveraging it to the maximum to make sure that we can use it to engage our patients, and to use it to help us understand how the patient is doing at home, making sure that they feel empowered, both themselves and the families, in communicating with the care team, and to make sure that every part of the care team have access to the best-in-class information and in the most up-to-date manner to take care of the patient. I do think that one of the things that we will need to continue to work on is how do we facilitate communication in a fast-paced environment where clinicians may be geographically dispersed across different locations, where we will need to take care of patients across different disciplines, even when the patient is not directly in front of us. And this is where I think telemedicine technology is going to open up a whole host of opportunities for us to not only be closer to the patient, even if they don't travel to us, but also make sure that we can actually monitor the patient closely in terms of their physiological parameters as we move into the pub health world.
Thank you. Dr. Snyder, what are your thoughts?
Yeah, I tell you, we take care of patients on islands here. So I hear your message with that telemedicine and ability to cross that chiasm. We really, I mean, since we've gotten Epic, we've seen a huge benefit to the integration with our offices throughout multiple institutions, plus throughout the state, using Care Everywhere. So, you know, that's all communication. But, you know, again, my biggest emphasis would be to how do we get that patient communication that is literate to them, usable to them, and that's one huge benefit to having an open source. The other problem I see is that communication among providers, and as a hospitalist, about 10% of what we do is critical and needs to be managed now. And I think there's still some holes in that area for communication where we really need to have a better alignment with our focus on those tools. And maybe using messaging that is secure could possibly be a solution for that, especially within a hospitalist group. And we've started trialing some of that using Spoke. And we've also done some extra work with group paging that's been really successful over the last couple of years. That's really leveraged that urgency to a very focused group that's identified within the four walls of the institution. So I think that communication is a very broad term. whether you're talking to clinicians, whether you're talking to patients, whether you're talking to payers, insurance payers, et cetera. So we really have to define those areas and kind of get some ground rules around it. And I do worry about, I think Dr. Pooty said earlier, the interpretation or the expectation of what you're going to do with that communication really is very new with all these tools that we're gaining.
And Dr. Snyder, maybe I'll follow up with one of the comments that you made. You talked about some of these ability to page a group of people in different situations. I think one of the ones that you're focused on is with the Muse score and sepsis. And maybe just share a little bit how you anticipate or how you see that working in your organization.
Yeah, currently we're utilizing the BPA and Epic to fire a page to a certain level of Muse results, and we started off fairly large with that, and we had to cone it back real quick. But I think going forward, we're getting better at more specific targets that we need to shoot at, and each of those targets has an algorithm or a plan associated with it that's driven by protocols at the bedside. So we can rescue patients in a much better fashion. I think sepsis, and I know we're working with Hopkins right now to develop possibly some sepsis avenues for that also. That is even more specific down to a specific disease process that hopefully we'll be able to engage some of these communication tools to again, target those resources, I call it automagically, into the system so we can really drive that care to be more expeditious.
Yeah, I think it's exciting how you're using the information and insights gathered in the EHR through this case through the clinical decision or best practice alert, and then using it and sending it to the targeted team, as you said, through your communication platform so people can react to it quickly and you're not counting on a human being, for example, to leave their workflow and then try to manually call, for example, a rapid response team. That's great. I'm looking forward to hearing the results of some of your studies. So, the next question is really an interesting one where, for all the sophistication that we have in technology today, one of the hardest problems organizations face is figuring out who the heck do I call? I was recently at a focus group or leading a focus group, and one physician from an organization said, they had an organizational initiative to try to be really good at keeping track of the care team and making sure everyone had access to the call schedules. This was one of their very top organizational priorities. And a few months into it, they gave up because it was just too hard to figure out. But yet I think your organizations have done a pretty good job of figuring out that problem of who the heck do I call. So I'll start with you again, Dr. Snyder. Maybe just talk a little bit about how your organization knows who do I call when I need help.
Yeah, the old days we used to call the operator, hitting zero and hoping they had a accurate schedule that wasn't scratched through 10 times by the providing group. Was always a challenge, and I can't imagine doing this at Duke. We have 400 medical staff, so I'm curious to see what Duke's doing. But we're very excited that we're able to actually organize it enough, and we have a wonderful operations team centrally that manages our list, basically, and keeps that up to date. And through that, we're able to link directly from our EMR through consultation orders to that list. So it's at your fingertips. So there's really, it eliminates a lot of the delay and the potential miscommunication of information through basically a duck, goose process of you're next to take that message and get it to the right target. So physician targeted paging is where we've gone, and our IT department has done a fantastic job of making that list available to us through the EHR also now.
Great. Now, Dr. Griffith, I know at Duke, it is a very complex environment with residents and interns and attendings and fellows constantly changing and changing literally hour by hour. And I think you've worked out a pretty good system, though, that not only allows people to keep track of who to call, but also I think allows you to have interconnectivity into your EHR. So as messages or orders are placed, the right person gets the message in a communication model. So Dr. Griffin, if you don't mind talking about that a little bit about Duke and how you're managing that and how you solve some of the problems there.
Yeah, absolutely. I think you hit the nail on the head, the changing landscape of how inpatient medical care is being delivered now, particularly with GME trainees and the duty hour restrictions they have for shift length and number of days they can work, et cetera, really has transitioned to it being team-based delivery. And then across different services, what the team might look like is very different. Some teams are large with multiple trainees and attending or a fellow, and some are maybe small with just a provider and a PA, but being able to identify kind of who the person to call first for a patient, as well as how do we connect between teams if you're trying to reach out to a consultant, has been a large challenge that we've tried to work at from multiple different angles to leverage our communication platform to improve. A big piece of that is that we have adopted use of things we refer to them as functional pagers, so kind of role-based pager numbers that then individual teams manage on their own for forwarding to the person responsible for that role. And we've had that both for primary teams, so like the general medicine one team can have a single pager number that will reach the doctor who's in-house responsible for those patients 24/7, as well as for consultations. An example of, again, how complex we are, we have 4 different nephrology consult teams at Duke University Hospital, which cover acute consults, maintenance dialysis, transplant, and some other issues. And then not only figuring out how do we reach a message to a nephrologist, but much less the correct nephrologist for this patient issue is something that we work on with the functional pagers, but have had benefits from integrating into the EHR. So we have the capability of sending pages through the EHR when orders are placed, and we use a workflow where a physician, when in need of consultation, can request place an order for the consult. The consult questions can guide through decisions and help set up through order transmittal on the back end when and who gets that message paged out. For an example, then a stat consult to someone who needs emergent dialysis will go to the acute dialysis consultant immediately. A routine consult for continuing maintenance dialysis may not generate a page, but may just go into a list in the EHR that team reviews on a daily basis. So the combination of the EHR and the communication platform has led to us having a lot of flexibility to make sure that the critical messages go to the right person consistently, but also has had supported workflow that allows for some things that used to require pages to now be distributed in other channels and reviewed more electively at certain times of day.
Yeah, thanks. And, it's fascinating when I had a chance to visit you at Duke, while the terminology is still pagers, it's really what you call functional pagers, really a role. So everyone knows there's just one single way to get in touch with that role. And whether that person's carrying a pager or it's coming to their mobile phone, it's all one way. So as a caregiver, as a nurse, as a physician, doesn't matter who they are, what they are carrying, what location they're at. There's always the same common way, and I think you've created a very efficient system for an extraordinarily complex environment. So let's move on to the next question. This one, to me, has been really fascinating as I've been involved in this communication technologies. I spent a long part of my career with electronic health records, including spending time implementing the EHR at a very large and complex health system. And we spent a tremendous amount of time with change management and preparing the organization for the change, including process reengineering and workflow analyses and training and so forth, and physician support. And then it's been really fascinating to see a number of organizations, they look at communication technology as sort of, I'll just throw something out into the physician's hands and magic will happen. If you build it, they will come. And just like almost every other technology in healthcare, it's never that easy. I know at both of your organizations, you've thought a lot about this and put in a number of programs to help with the adoption of communication technologies. So maybe I'll start with you, Dr. Griffith. If you want to talk about how you view the change management programs and as you put in some of these communication technologies and the importance of that.
Absolutely. I think one thing that was a benefit of, we moved to Epic in 2013 was our first install, and we have done an enterprise installation. And one of the things that came out of that with moving to an integrated EHR was really a need to kind of integrate the decision making about how we apply and decide which technologies to implement here at the enterprise. So through several kind of iterations, we've evolved IT governance processes for reviewing, approving, and implementing projects. And those, I think, have been well-resourced to be clinically oriented, staffed largely by the clinical front staff, not IT liaisons to those governance groups in support, but it's the clinicians inputting and making decisions about what's right to try to align with our strategic priorities as a health system. And governance isn't just about the electronic health record or this other piece of software. It's kind of all application of technology and clinical care, including things like the communication platform. So I think across all things, not just communication, but the EHR, and if we're looking at a new vended project, we have a pretty robust process to look at the technology, engage with staff and stakeholders to evaluate the pros and cons of it, and attempt to apply it as a system and look for a unified solution that works for all three of our inpatient sites, the ERs, the ambulatory, and keeps the patient kind of in the center of what we're doing. So I think to that end, we've been successful with the adoption of Spoke here, replacing kind of our prior back-end technology. We went through a large deployment, reaching out to users to swap out old pagers for encrypted pagers or to train people on use of the mobile app if that was their preference, and allowing flexibility to users to kind of understand and decide which kind of device works best for the work they need to do and the messages they need to receive. So I think it was one of the more, I think it was a very successful implementation, but also extremely well coordinated and thought out with the needs of providers and patients very much in mind as we made these decisions.
That's great. Yeah, it was exciting when I was there to even have like little tables set up, or, you know, I remember like in an EHR rollout, you had support staff. Well, you did the same thing with your transitions of communication technologies. Dr. Snyder, what are your thoughts?
Yeah, we actually have had Spoke for some time, and I think with probably one of our biggest challenges up front was just getting the private providers schedules and the accuracy of that, and luckily we have some excellent operator staff that have really engaged this and taken it to another level and organized it and held us accountable to that, which is a good thing. But one of the benefits I see of this tool is, you know, bringing on new providers as I train them in our EHR. I think that, you know, when they see how the communication access to information for a new provider coming into a rural hospital like us, you know, finding out who to call is always just really a challenge based on specialty. So this tool just gives you a great window into that library of information. So it really does help the newer providers. You don't have to remember phone numbers like the old days. You don't have to remember, you know, pager numbers, names even. It's fairly simple to search and find out your needed resource at that time. Because one of the scariest things for a doctor right out of fellowship is being a doctor right out of fellowship. And, you know, again, it's fairly stressful the first 6 months of life. And the last thing you need to worry about is, oh my God, I need help. Who do I call? And really, when you don't have a lot of house staff running around, we're all private docs attendings in our institution, like many of the smaller hospitals in the country. Boy, is it nice to be able to grab that critical care guy or cardiologist with just a click of the button and a text message to them. So I think that's probably where we've seen our largest value as far as, you know, training. The implementation, all in all, just it took years of development and build from our operations staff.
Yep. Thank you, Chris. Mm-hmm. All right, so let's go to the last prepared question. You know, it's fascinating how physicians are often stuck in some of their older ways. I was working with an organization recently where they were worried about how a certain physician would handle moving from getting purely numeric phone number messages to really even just a richer message that had the patient information, like a patient name in it and room number and why they're calling. So, and at the same time, these different technologies have different strengths and weaknesses. So what we see with consumer technologies like your iPhone or Android phone is they're great. You carry a single device, but you still run into challenges of network connectivity, people putting their phone on silent by accident or putting on do not disturb and missing information with restrictions that the manufacturers put in place. Well, at the same time, pagers are tried and true. They're reliable. We've seen instances where the cell phone network goes down, but because of the way that pager technology works, it's still up and running. So with those strengths and weaknesses of those technologies, we see many organizations, including both of yours, really having choices and a diversity of devices. And maybe Dr. Snyder, just talk about some of how you see blending the traditional pager devices, which still have a very important role and widely used by physicians, with the emerging consumer technologies.
Yeah, I think, pagers in general are the gold standard still, and we still use group paging in a number of different areas. But, honestly, pagers are very one-sided, so it's just a message to you. The sender really doesn't get any acknowledgement of receipt. I think there's a large potential using smartphones, and we still have some dark holes in our hospital that we don't quite get the right response time to a page into our phone. But all being said, we've developed a culture where, again, the providers do have a choice in certain instances where it's a group page or our hospitalist pager, much like Duke has done. We have one pager for the on-call hospitalist or hospitalist groups that are on. And that one page really is kind of the backup for the other pages, but many of them have chosen the mobile app because they actually get a lot more information, and then they can accept, decline, or even search alternate people to page in the same workflow. So I think we're evolving over time. I remember a day where I had a bag phone and a pager in my car, and that was pretty much the only person who had a cell phone at that point in time. As we've migrated forward, I had 5 different devices on me at once, and I thought I was going to develop a malignancy from them because I had so much radiation on me. Now I'm down to pretty much 2 devices. So I think we're getting there, but I think we still have a fair amount of work to do, and I think a lot of it has to do with the etiquette of paging, the information exchange, and PHI obviously is always in my mind.
Thank you, Dr. Snyder. I know, Dr. Griffith, as you made this transition, you're still very much supporting both and allowing people to choose or have both. But if you don't mind talking about how you're evolving.
Yeah, I agree. I think flexibility of the implementation has been key, both for getting allowing to support the early adopters who were very eager to move to the mobile app to carry a single device around, as well as supporting, people who have a lot of invested muscle and mental memory about operating their pager and are just used to that channel. We're still some places where, for absolutely critical, timely messaging, like our code pagers and RRT pagers, those are still manual. We maintain a manual pager for those just because we cannot risk any network connectivity issues and distribution of those. But for the personal messaging that I'm thinking from the physician perspective, if they're getting, I think they can choose a solution that marries most to their expectations, or even have the option of doing both. As mentioned earlier, I kind of split my time between clinical care, sometimes working directly as a hospitalist, taking care of patients by myself without a team. Other times I'm working with residents, and I have administrative time when I'm working on our IT parts, and the kind of need I have from a device differs in those environments. When I'm doing IT projects or working with the residents, the kind of volume and acuity of pages that I receive is less frequent and less acute for respond, and I enjoy the flexibility of just using the mobile app to carry one device with me. At other times, if I'm on we have one of our providers in the hospital is triaging and accepting patients from our ER, covering the transfer center and consultants, and kind of timeliness of response and the volume of messaging is very high. And I have peers who do that on the mobile app just fine, but I've kind of had a decade of working with my physical pager that I've had a system and a process that I still find very familiar and easy to use set up. So when I'm on that rotation, I choose to go with the old school pager for receiving my message, and we allow through the paging portal, providers can log in and switch which or both methods they want to get. So I can just go to our website and say I want to get my messages to my phone right now, or switch it over to the pager, and you can have that degree of flexibility with how we've implemented. And I think providing that choice, providing that flexibility led to a very successful implementation, because it wasn't IT or the leadership saying, you must do it this way. It was like, here is a new way. It might work better for you, or let us show you this new way and let you choose if you want to, adopt it. And some jumped at it, some held back, but as they saw their peers going to that and talking to them about how it's going and seeing how reliable and happy users were with it, more followed suit. And I think, as needs exchange and as capabilities like two-way messaging and read receipts and other stuff may become more useful, I could see that those capabilities that the mobile apps have that older pagers do not could drive more and more people toward that part of the platform.
That's great. And as you mentioned, the pagers have evolved. They're now encrypted pagers, so you don't have to worry about PHI being sent unencrypted over the air. There's also even two-way pagers that allow you to respond to messages if you want to truly keep a separate device from your personal device for managing messages. So with that, we've kind of wrapped up the formal questions. We're getting a number of questions in via the GoToMeeting. So if you have other ones, please type them in the Q&A box, and I have a couple I'll start off with. Maybe this will be for both organizations. I'll start with you, Dr. Snyder. As an organization thinks about investing in messaging technology and a communication technology, how would you have them think about making a business or clinical case to make that kind of investment? What is the sort of value that you would ascribe in a business case as you think about making that kind of investment?
Yeah, the clinical case, I think from what you've heard the last 45 minutes or so, I think it justifies ease of use and accessibility to proper management. One of the most challenging things as a physician is that we can't do our job without information. We review information, make decisions, diagnostic decisions, prognostic decisions, et cetera. And I really think that you have to leverage how that information exchange occurs, so we can apply those decisions to the bedside. Without a good communication tool, one of the most frustrating things to do is come in an environment when you can't get a hold of somebody. It's just, I don't know. I having children, I tell you, when they don't call me back on their cell phone in less than 30 seconds now. Years ago, when my parents called us, they didn't have to worry about that because there was no cell phone. But clearly, you get that angst in your gut, and we're responsible for these people. And I think that clinically sells the business case of why you need to do this. Now, the cost of it is, again, something they don't let me talk about, but the clinical case I can definitely sell.
Thanks, Dr. Snyder. Maybe Dr. Poon, what about your perspective?
Yeah, I agree with everything that Chris has said. I think I would add that one of the drivers, amongst others, that we have used is improving physician and provider resilience overall. I think that more and more we find that everybody is being asked to do more with a fixed bucket of time, and the more we can help our clinicians be more efficient and effective at communicating with each other, the more we're going to be able to do for our patients. I think as a case in point, I will point to how we are on a journey to think about how we will offer communication technologies, not just to our providers, but also to our nurses. So we are actively exploring how we will deploy the handheld devices to nurses at the bedside to help them not just scan medications at the point of administration using a handheld device, but to also look up clinical references. And as part of the effort, we will be introducing spoke technology to them. And once we do that, then the communication between nurses and physicians could undergo a sea change, whereas before a nurse might have to page an intern or a resident for a medication order, and then the resident intern might page back 5-10 minutes later, only to find that the nurse is busy. With two-way communication technology on both ends, the communication can be much more streamlined. Pages that historically have been just FYIs can now be sent with a two-way communication technology without requiring a callback. And that is really going to improve provider satisfaction and overall clinical throughput, not to mention improving physician and clinician resilience.
Great, thank you. So here's another question. You know, as the EHR is sort of front and center of most organizations and their core clinical technology for how they use it, what do you see as sort of the differences between your communication platform and your EHR as really being complementary to each other? Even as EHRs evolve and add more capabilities, you know, the communication platform includes call schedules, it includes the hospital operators, includes device connectivity, and many other aspects. So how do you see these two solutions really co-evolving over time and playing complementary roles to each other? So maybe I'll start with Dr. Griffith, if that's okay.
Sure. I think they very much complement each other in a degree that they, you know, the integration between the two or the reference of one to the other can be helpful. I think, you know, the electronic health record, and particularly having the patient context and information there is huge. We're big on having our patients, you know, leveraging communication to the patient and receiving from the patient through the EHR and portal. So that's a very, very important channel for our communication and engagement to the patients. At the same time, like, we have parts of our enterprise that are not clinical, but need to get messaging and need to coordinate services with each other and don't need access to patient health information and the security that goes on to that. So having some separation between the EHR, where we can focus patient-centered care and coordination amongst care team members and leverage, you know, integration into Spoke through things like the consult orders or the functional pagers being listed in the patient record has been very important. But at the same time, there's an entire swath of our enterprise of people who need to be able to get and receive messages, some in a very timely manner, who don't need access to PHI or the patient chart, but still need to be able to do their job. So I think those two different kind of pieces of the puzzle fit together nicely with how we've implemented Epic and Spoke here at Duke Health.
You, Dr. Snyder, what are your thoughts?
Yeah, I totally agree. Took the words out of my mouth. I think there's definitely a difference, and I look at the enterprise version of Epic we've installed, and there is clearly non-clinical reasons for messaging amongst my group for as far as scheduling, as far as there's a huge amount of information that really doesn't necessarily need to be housed within the application. So, I think Spoke would have a great opportunity. Also, it's a outside source, so it does not become part of the medical record. So, you know, again, how that's utilizing those tools, I think we're all going to have to cross this bridge, because the vendors are definitely proposing a messaging tool within each EMR. So we're going to have to walk through that, see where the use cases are. But again, that flexibility of having multiple communication tools is not a bad thing. I don't think we should have 5 phones on us, but I think 2 is okay.
And Chris, maybe Dr. Snyder, this one maybe is a clarification question for you. The question is, how do you maybe talk a little bit more about that automatic connectivity for critical situations like sepsis, and not necessarily from a technical side, but the workflow of how it's realized in the EHR, and then what the sort of processes or thought processes of getting the right people to respond in an emergent situation or near emergent situation like that. So just talk through that walk in a little more detail.
Yeah, we implemented Muse about 8-9 years ago, actually, in our institution, and clinical change is just really a behavior modification. The Muse isn't a trigger. For example, it's a trigger for an alert that it actually rescues patients long before they're in a critical state. And that's where we really found our value 8-9 years ago when we implemented our Muse and reduced our code blues. We increased resources to apply that, but I think one of the challenges everybody has to realize here is, the sooner we get an activation of a process, the more likelihood that the patient's going to have a better outcome, because time is brain, time is heart, time is life when you're talking about sepsis. And clearly, the sooner we can move that target to the front so that the care team that's responsible for that patient thinks about that. And we're all probably in healthcare on this phone call, but one of the most difficult things is to say, I didn't think about that. Wow, that's just, and in those scenarios with acute MI, with a sepsis patient, with an acute stroke, I mean, we have the strokes being thought about by the patients in the field. Why? Because they can't talk or they're facial. So we need that kind of advertisement in the clinical settings too. So the non-physician, non-nurse, even the bedside CNAs have the ability to say, hey, there's something wrong. Maybe I should ask for help. And I think that's where the automatic cases of these can occur, because at least it brings in a second, third, fourth set of eyes to say, hey, you know what? We have an opportunity here to rescue somebody. And that's, I think, a goal that every inpatient institution should shoot for, and also in the community too, if that's possible.
Yeah, that's great. So, what's interesting is you describe a situation, a really critical situation, of taking an event that happens at the EHR and getting it to the right people. This is a follow-up to some other questions we've received, but what's been fascinating for me is how people use that same core concept to be really creative and do other kinds of things, whether it's a code situation or someone coming, a trauma alert, but things like when the patient's getting discharged, sending it to the valet service, helping sort of the greeters know when someone's coming in and being able to communicate with them, or when patients' status changes in the OR, communication with that family member. So being able to take sort of those events that have happened, whether it's in the EHR or some other device, and getting it to the right people becomes an extraordinarily powerful tool, not just in clinical situations, but really in helping improve patient and family satisfaction and helping keep the organization running.
Okay. I'll add to that, Andrew. Research recruitment has been a big issue at us at an academic center, and being able to have triggers in the EHR when patients hit certain criteria or meet inclusion criteria for potential for a trial, to be able to message research coordinators in a timely manner that there's a patient who will be in X clinic today that may be approachable, or that just got admitted to the unit, particularly for like critical care studies where there's maybe a small window of time to enroll them. Developing strategies to message those pieces of the research team about these patients has been successful, and has been a part that we developed here at Duke even prior to Epic to help drive and accelerate research enrollment, so we can start developing those next bits of knowledge to disseminate.
That's a great example. For an institution like Duke Health, where research is a core to what you do, to be able to have that person waiting at the clinic, or know immediately when they walk through the door, get them enrolled in the latest study, and that's really a very patient-centered approach, and also advancing your mission. That's excellent.
Yeah. So, Andrew, if I could jump in there, I just want to add to what Chris has been talking about. I think what we have learned as we've implemented things like sepsis alerts is that we can afford to be creative about not just who gets alert, which patients we get alerted about, but who receives the alert. And I think when it comes to risk scores that are not always 100% predictive, we have found that it actually at times might be helpful for these alerts to go to a centralized pool so that there is literally a second pair of eyes looking at the risk of sepsis development in a population of patients across the hospital, and having somebody else, a separate team thinking about who are the patients that merit a more detailed evaluation so that we can start bringing resources to bear to prevent any further patient deterioration. So these are some of the lessons learned, and I think communication technology that inherently allows us the flexibility to configure not just the clinical message itself, but how it gets sent, how do we make sure that we have the right lines of accountability, I think is going to be an important component of what we do.
Yeah, that's excellent. Maybe one last question. You know, we've talked a lot about some paging, and I think we talked a little bit about sort of the two-way messaging and be able to respond. How do you see this evolving as everyone is on the same two-way communication platform, and what used to maybe take a phone call or require, you know, sort of that time waiting when trying to find that right person changes when you can really have a very efficient asynchronous communication model that's not just between the physician and to their, say, consulting physicians, but really to the nurses and the other members of that care team that are so important. So talk about how you see this evolving over the next years as two-way communication becomes the norm, and you know, nurses and physicians and the whole care team really have that fluid model of communication. So maybe Dr. Snyder, why don't you start with that one?
Yeah, that's very, very good thoughts. One of the challenges that I sense as a hospitalist is pressure points. And when you're talking about two-way communication, the visibility of information has always been a very big challenge. And I've been doing EMRs for at least a little bit over a decade now, working as a CMIO. And I've installed and worked with a lot of providers utilizing these things. And I think one of the pressure points is, you know, where are the pressure points? And I see examples like ED pressure for the hospitalist, knowing that we have potential 20 admissions on our next shift, and we may need an extra resource. So I see a huge amount of communication capabilities if there was a central dashboard that actually showed the traffic. My oldest son's a pilot, and when I sit in and standby waiting for a flight as a standby person, I can look up on the screen and see where I'm at in line. And I think that kind of visibility around bidirectional communication is really a powerful tool and could potentially just take a lot of the pressure off the angst of waiting for a page, waiting for a call. You know, again, expecting something to happen or anticipating it predictively with these tools is a future goal of mine. And how do we leverage the volume of data that's coming into our EMR and somehow publish that? So when my hospitalist is on call and they got 2 of them there and we got a potential overflow of patients, how can I get help so those patients can get a doctor quicker? One example of many in our institution that really, I think all of us feel every day practicing medicine at the front line is pressure. So how can we improve the visibility of communication to reduce pressure would be a huge goal for me.
Thanks, Dr. Snyder. And Dr. Griffith and Dr. Poon, do you have thoughts on this topic?
Yeah. So Andrew, if I can jump in for a second, I think that the communication tools are definitely evolving, and I think two-way communication will be a centerpiece. I think one of the things we've recognized in the last year is that in order for us to use these tools wisely and not introduce more unintended consequences than is necessary, we really need to make sure that even as the technology evolves, we have a brain trust within the organization that looks at looks at how we will use these tools across different disciplines. So one of the things we've done in the last year is to form a committee around clinical messaging here at Duke, comprising of both physicians and nurses. And of course, we included the graduate medical education stakeholders because that is an important stakeholder. And those folks work together alongside with our technology folks to understand what's coming online, what's going to be available, what are some of our vendors working on over the next year, and what are the choices available. And when we make decisions about the tools that we pick, we really have to think through how we're going to deploy them. You mentioned earlier that deploying communication tools is like deploying an EHR. I couldn't agree more. So many things could go wrong if you don't think through all the different scenarios, think through the change management steps, and support the change and hold people accountable for complying with the new standards of communication. And I think there is a lot that we can learn from each other across different organizations as to how we take advantage of the evolving technology.
Thank you. Dr. Griffith, do you have any? Go ahead.
Yeah, I agree. As the technology continues to evolve, I think we'll have opportunities for new ways of communicating. And I think it just, with each of those new ways that develop, it just hopefully needs to be supportive of the mission, like taking care of patients and making it easier and safer and more efficient and more reliable to do so. Sometimes adding another channel may detriment a more useful channel. Like there's some things that are still best verbally communicated, maybe not over a message, or need to be done at the bedside together as a team. So I wouldn't want to see, certain functionality replacing things like, rounding at the bedside as a team with your nurse or with the multidisciplinary team where it makes sense. But to the degree that these technologies can help us maintain those connections even when we all physically can't be, co-located at the bedside, and make sure that messages get to the right people in a timely manner. I think that helps us achieve those goals. I think in addition to, we've had the discussion about bidirectional, so a physician to a nurse can have discussion. I think the options and multitude of options that could come for like group chatting amongst a specialty or within a team, or from a nurse to an entire team of physicians, will present opportunities, but also a lot of challenges, because when you kind of move away from a single point of contact to a nurse saying, I can message the entire care team, do you lose kind of a who's responsible for dealing with that concern if it reaches 6 doctors simultaneously in the team, who takes the lead on responding. So I think these will be good challenges to rise to as the technology matures. And I think as long as we keep the patient and patient care as the mission at front of mind as we consider how we implement these, we'll do well.
Thank you. And as we come to the top of the hour, I first want to especially thank my colleagues, Dr. Snyder, Dr. Boone, and Dr. Griffith, for their very insightful answers and really sharing a lot of their well-worn, their hard-earned experiences as they've thought about this and have rolled out communication technologies. I also want to thank Becker's for helping host this webinar. So with that, I'll turn it back over to you, Emma.
Fantastic. Thank you so much, Dr. Mellon, and thank you to Spoke for sponsoring this fantastic presentation today. That concludes today's webinar, and we look forward to having you join us for future programs.